So with that, I would like to welcome you all to our call today. We are very excited to have some dynamic speakers. I'm here with Jackline Kiarie from Kenya, who is our Regional Program Manager of East Africa Global Health Security Unit. And she's been working with Amref for an undisclosed amount of time. And then we're also here with Boniface Hlabano, who is also our Regional Program Manager from the Southern Africa Global Health Security Unit. And our wonderful CEO of Amref USA, Bob Kelty. So I'm going to turn it over to you, Bob, for a little brief intro of what our talk today is and put myself on mute. Enjoy.
Thanks, Jenny. Thank you, everyone from Canada, the United States, the UK for joining us on this call. Very excited to talk about our new partnership with Africa CDC, and really happy that both Jackie and Boniface could join us. They're two of the busiest people at Amref, always traveling around and have so much responsibility and doing such amazing work that I'm really looking forward to letting them share that with you. So just a really quick brief on Amref and kind of why we wanted to talk about our partnership with the Africa CDC, besides being very topical about vaccine outreach and vaccine delivery. I think it really sums up who Amref is, this partnership, and why we're a little different than other organizations. I think, as everyone knows, Amref's work, we do water programs, maternal and child health programs, sexual reproductive health programs. But our core work, where the majority of our what we do is go right around health capacity building, human resources building, training, building organizational, community-based organizations, which is really why I think we're in the position we are right now as a local African NGO. And just going back to when the Ebola outbreak happened, there was a lot of Africa really played no role in the response, or played a very limited role. And I think most of the money that was spent went to northern organizations, northern bilaterals, but Africa really was frustrated that they didn't have a role in saying how the response should be, what their role should be. And so right after the Ebola outbreak, the African Union set up a group called the African CDC, which would be their health arm of the African Union, into technical, operating similar to the American CDC, same kind of technical support, really be the leaders on this. And so I think it's really changed as an African organization. It's the first bilateral health organization that's, Africa-based. It was the first. So that is, and during the COVID outbreak, Africa CDC really became, in my opinion, a major voice on how, the response to COVID should be, the challenges facing Africa. And then I think even now, even another bigger step is the COVID vaccine rollout and the technical support they're doing for that. And so why Amref was chosen as their partner to work with governments, to work with the healthcare systems in 30 countries in East and Southern Africa, was because we were an African NGO. And I think that goes back to our roots in 1957. We really haven't done or changed really our core work, which is building health systems. So it's been an incredibly important work we're doing. I think Amref has changed so much just since the 8 years I've been here. And I think this is some of the most important work we will be doing as an organization, and having Jackie and Boniface, who are leading that work, on board to really kind of talk about how it works, both from this, a little bigger picture kind of the country level, but all the way down to the clinic, I think will be very informative. Because I think a lot of times we're still talking about, and you're reading the newspaper about, there's not enough vaccines in Africa. We're talking about problems. There's vaccine hesitancy. We're talking about issues that were there before, but now we're not talking what is, as the vaccines start coming in, what do we need to do to make this successful and effective and get as many people vaccinated as soon as possible. And I think it's, Jackie, would you like to start with showing a few slides of, the work you're doing? She'll help put it in context, kind of the work we're doing, the challenges that they're facing, and kind of the plans for the future.
Great. So as soon as I get the right to share my screen, I will pull that up.
Give us 1 second, Jackie.
Okay. Has it come up?
Yep, you're good to go.
All right, thank you very much, and really excited to be part of this discussion today. I work in Amref, like my colleagues have mentioned, and have been supporting the COVID-19 response in the region for quite some time, basically from most of last year to now, when we are now more involved in the vaccination program. I will be talking about what we are doing, especially in our partnership with Africa CDC, which is basically supporting most of the vaccination efforts across different countries in Africa. And what I have here on my screen is an example of one of the sort of vaccination centers that we are supporting in this. This is a typical vaccination center in most regions in Africa, actually. And this was the earlier plan. Most governments, most ministries of health thought it was going to be an easy assignment of simply identifying what health facilities qualify for the COVID-19 vaccination based on the kind of infrastructure that they have. So for example, in this particular one, this is likely to be an inpatient clinic with about 5 rooms, with about 5 healthcare workers, basic childhood immunization infrastructure. So if you go in here, for example, you're going to find a domestic fridge, which allows us to store the AstraZeneca kind of vaccines, the ones that do not require the ultra cold or the frozen kind of temperatures to maintain their potency. This particular clinic is somewhere in Kajiado district in Kenya, which is a nomadic site. And this is basically one of the sort of clients that have been targeted in most vaccination programs here in Africa, very similar to what you have in the West. Clients above 58 years, clients who might have the sort of chronic illnesses like diabetes and hypertension. We are targeting our frontline workers, such as our teachers, our prison workers, our military, our health workers, who are really the ones meeting the patients. So I hope that provides a bit of context in some of the places that we are working in. I know my colleague Boniface is going to talk more about some of the work that is going on in South Africa to just try and help the team understand what the vaccination efforts in the region look like. So where are we now as a continent? Of course, we have a target of vaccinating most of our populations, the ones who qualify, about 70% of them. And that's to get that done, we need about 1.8 billion vaccines. Unfortunately, we only have a supply of about 37%. So a very clear gap in as far as access to vaccines is concerned in the region. But that said, we've not been able to administer everything that we have in the continent. As you can see, only 12% of our population has been vaccinated. About 60% of these vaccines have been administered, which means we still have some vaccine in the continent that is available now, should be administered, but has not yet been administered. And the reason we have that problem is because we still have challenges in our vaccination program. If you look at that map, for example, we have different shades of green, and the different shades represent how far each one of these countries has gone in as far as reaching their populations in the vaccination program. We have darker greens for the countries that are doing fairly well. Countries like South Africa have been able to administer more than 90% of the vaccines that they have. Countries like Egypt are already at 99%, which means they've been able to administer everything that they have. Countries like Morocco, the same thing. When we come a little bit down, we have countries like Kenya. We've only been able to administer about 50% of what we have. Tanzania, which joined the bandwagon quite late, has. And what this means is that we have different capacities as the region, because we are not equally prepared. Our health system are not at the same level, even we have in the world, really trying to ensure that everybody can get access to the vaccine. So right now, as we speak, most of the countries in Africa already have some vaccine to work with for the next 1, 2, 3 months, but we are still struggling to ensure that this vaccine can get into the arms of those who need them. And the reason for this is that we still have very low vaccine absorption capacity. We do have the vaccines, but the vaccines programs have not been well resourced. You'll find that most of the time, our health workers need to take the vaccine from the health facility to support the outreach centers, but sometimes you don't have vehicles to take our health workers to where they are needed. We don't have vehicles to transport the vaccines from the regional stores to where they are needed. We also have such complex decisions we have to make as countries. For example, if you come into a country like Kenya, they are still trying to decide exactly how many vaccine candidates we need, because the more vaccine candidates you have, the more the times you have to go back and train your healthcare workers, the more you have to keep upgrading your cold chain, the more you have to keep investing in the supply chain to just ensure that you can be able to administer these kind of vaccines in the shortest time possible. Because most of these vaccines are coming into the country with a shelf life of not more than 3 months, which means you have to work really fast. And considering that we are working with the same health workers, with the same health system that is supporting all the other health problems that we have, then it becomes very complicated. We also have challenges with vaccine demand, hesitancy, as well as access. Trying to make sure that though we can convince the ones who need to be convinced, that we can reach the ones who are in the farthest of places, we are still struggling with that. Vaccine demand, because I think we are all aware there's a bit of laxity. There's a bit of feeling that COVID is no longer a threat. And as we well know, whatever happens out there eventually trickles down to Africa. So trying to really ensure that people can still feel the risk, that people still feel the need to get vaccinated is still a struggle. And therefore looking at what resources we have in hand to ensure that we can sustain the interest in getting vaccinated amongst the people that we are working with. The other challenge that we are facing right now is also on data management, because if we can't track how far we have gone in the vaccination efforts, then we cannot be able to make the right supply projections. We cannot be able to have targeted campaigns in the areas that we are working with. So the problems are still there. Governments are struggling. We are trying to mobilize funds as much as possible. We are seeing governments commit funds to procure the vaccines, to try and support the vaccination program, but we are still struggling with that. And that's part of the reason why Amref has partnered with Africa CDC in a really big way. And I think, as you're well aware, Africa CDC is the one regional organization that has been mandated to coordinate the response here in the region. And that means helping countries even prepare for the vaccination program, offering technical support as needed, tracking the vaccination efforts, trying to support countries, mobilizing resources to support countries to ensure that we can vaccinate as fast as possible and also prevent vaccine expiry in the region. Right now, we are talking about expiry of less than 1% of all the vaccines that have been donated to the continent. And we really hope that we can keep it below that, even as we try to reach as many people as possible. So for the better part of last year and this year, we've gotten into a very strategic partnership with Africa CDC. We must be one of their strategic partners because we are really working very closely with them to ensure that we can support as many countries as possible, given our expertise, given our knowledge of the region, given our physical presence and our ability to partner with others. Then we're able to really help Africa CDC scale their programs across quite a number of countries in the region. So right now we have about 31 countries covered under our partnership with Africa CDC. And these are about 11 projects really focusing on quite a number of areas. And all this is being coordinated from the Global Health Security Unit based here in Nairobi. Part of what we are doing with Africa CDC is strengthening their core capacities. And that means looking at their staffing needs, what kind of capacities do they need, and how can we support them to get more human resource that is going to support the coordination efforts in the region. And therefore, we are working with them to staff their regional headquarters, which is based in Addis. They also have the regional coordinating centers that are strategically placed in 5 countries in the region. So looking at what kind of staff do they need, and then of course, working with them to ensure that this staff is recruited, supported to perform, and then of course, really ensure that we can be able to move the needle in as far as vaccination is concerned. So that is one core area that we are supporting in as far as working with Africa CDC is concerned. The other area is around ensuring that we can increase uptake So accelerating all the efforts on these vaccination efforts in the region across the 31 countries. And part of this is really around institutional strengthening. So looking at what curriculums are being used to train our health workers. How can we ensure that our national public health institutes are better prepared if and when we get another sort of health emergency like what we have right now? So working with Africa CDC, health training institutions to review the curriculum, train our health workers, train the leadership in some of these national public health institutes to just ensure that we are better prepared for the current response, as well as when and if this ever happens again. The other thing that we are doing is around vaccine administration, so supporting the COVID vaccination centers to ensure that they can be able to administer the vaccine, to ensure that they can be able to conduct the outreach activities as expected, preparing the healthcare workers as far as training is concerned, ensuring that we have the right vaccine commodities in these COVID vaccination centers. So quite a lot of work around making sure that the countries have the COVID vaccination centers, that these COVID vaccination centers can continue to perform as expected. The other one is around procurement of some of these commodities, the vaccination commodities. We are working very closely with UNICEF, of course, with support from Africa CDC to procure, to deliver IPC commodities, to deliver case management commodities across these different countries, as well as other essential medical supplies that are needed across the different countries that we are supporting. The other thing that is very critical is around demand creation. And like I've just mentioned, this is still a struggle in the region, especially because there is quite a bit of low risk perception amongst most of the people who are targeted, especially those who are below 18, the 15 to 18. They don't see why they should be taking the vaccination. And therefore, quite a lot of work around working with the traditional leaders, the political leaders, the religious leaders, just trying to understand what the issues are and working with them to improve awareness at the community level, and then, of course, drive uptake for the vaccine. Data management is very critical because without this, then we cannot tell how far we have gone. So working in different countries to support their data management. In Djibouti, for example, if you look at the kind of system they are using to manage their vaccination program, it cannot manage their PCR tests. It cannot give you a certificate once you're fully vaccinated. And therefore, we are looking at how we can support them to up their vaccination data management, to move from the manual data collection to the sort of electronic data collection so that we can have real-time data to plan with. So that's also something very critical that we are supporting the Africa CDC with. And then, of course, pharmacovigilance, which has not been taken very seriously in most of the African countries. So what we are doing under this is working with countries to support development of the guidelines for a start, sensitizing the healthcare workers on pharmacovigilance, what kind of things should they be looking out for, working with our community health workers to also help them track if there are any adverse events following immunization, and then, of course, making the referrals as needed to the nearest health facility. So this is a summary of some of the work that we are doing with Africa CDC. We continue to partner with them, strengthen this partnership, because we are only at response, and obviously we should be looking at how we can build resilience in the African region. So Africa CDC remains a very strategic partner to us, just like they are a very strategic partner to, vice versa. So that said, we still have a few issues that we need to address to really get to where we are looking at. The first thing is really from the tarmac to the last mile. How do we ensure that we can strengthen our vaccination programs, especially the mass vaccination campaigns that most of the ministries of health are using to try and accelerate the vaccination effort? Like I've mentioned, there is a drive in most of the African countries to really take it from the static health facilities and take it to the outreach, making sure we can avail the vaccines at the marketplaces, door to door, at the prisons, at the training institutions. So how do we make sure we have enough resources to be able to cover those kind of efforts? The other thing is around improving our supply chain. So for example, in Kenya, if I think about what we have, 80% of our health facilities are still using domestic fridges to store these vaccines. So only 20% have the WHO approved domestic fridges. And when we think about the range of vaccines we are getting, some of them require to be frozen, Some of them require ultra cold chains to maintain their potency. So this is something we're still struggling with, and therefore looking at how we can support most of the ministries of health to strengthen their supply chain, especially the cold chain infrastructure. The other thing is around enhancing demand creation, because if the demand goes down, then we are likely to see quite a bit of vaccine expiries in the region, and therefore looking for ways of how we can strengthen capacity of our community health workers, give them the appropriate tools to be able to reach out at the community level, and then of course be able to support them for referrals and just ensure that we have changed perceptions, we have increased uptake at that level. And then finally, data management, because most of our people are using the manual systems that I've just mentioned, and there's a great push to really have this electronically managed. So trying to support the different countries that we are working with the equipment for this, the tablets, very basic sort of gadgets, but very useful at the same time, because then they can be able to go out, join the vaccination campaigns and capture the data as the vaccinations happen. So these are some of the things that we are trying to deal with, the kind of challenges we are still experiencing in the region. And we hope that we can be able to address this if we must really reach the targets that we are talking about by the end of 2023. Thank you very much.
Thanks, Jackie, for that very comprehensive kind of outlining what we've been doing, what we need to do. It was really helpful to me. And I think one point you brought up is we have to remember, sometimes we think only thing that these health clinics have to do is vaccinate people. And I think one of the things that both you and Boniface is working on is how do we integrate the vaccine, distribution into the current health systems. Boniface, do you have anything you want to add to what Jackie just spoke about? And then we can, I'll ask you some more specific questions.
Yes, Bob, thank you very much for this opportunity. I will try not to repeat what my colleague has already said, but maybe just add a few elements from some of the experiences and maybe some of the initiatives that we are already doing, particularly from the Southern Africa region. If I'm not sure, one of our colleagues, if you have a few photos just to flash them before I follow on what I want to say. Yes. So I will just share a bit in terms of some of the experiences, particularly from 3 countries in particular, Malawi, Zambia, and Lesotho. I'll also speak a bit about Namibia, and maybe time permitting, just pass a comment about South Africa. So in Malawi particularly, one of the things we are trying to do is to get the vaccines to the people, closer to where people live. Because one of the issues, even before COVID came, the issues of distance and access to health facilities has always been a challenge. So expecting people to go to the usual fixed sites is kind of a challenge. So just to give a perspective, in Malawi, as we speak, Malawi is one of the countries which is way below the continent average in terms of vaccination rate, as we speak, at about 9.7% as of last week. So my colleague spoke about 12% on average, but Malawi is far below that. Because one of the issues really is about use of distance, but also Malawi is quite an interesting country, particularly the southern region, which is dominated by very strong traditional customs and practices, and therefore issues of hesitancy are quite huge. This is then complicated by issues of access. So one of the things that Amref, of course, with support from Africa CDC and other partners, is to take the vaccines to the people. So you'll find that, as you see from the photo there, where we drive vehicles in communities where people live with the kit, and we just deploy community health workers ahead a week or so before the teams come to mobilize, educate people and readiness, and then the vaccinators will come, spend a day as they drive around, even walking at times into households to deliver these vaccines. And we have found that this is one of the issues that may help. Our situation was recently complicated in Malawi because of the cyclone which recently hit the country in the southern region, where it even made displacements and pushing people into temporary camps also affecting even the outreach in terms of access, where you will not necessarily be able to access some of these communities in an ordinary vehicle, whether you really need a high-level, high-rise vehicles for you to be able to get closer. Hence, we even found that at times we have to get our volunteers and vaccination teams to walk into the communities to deliver vaccines. But then this comes with the challenges of the management system, the cold chain, the cooler boxes. It means certain vaccines cannot be taken into those communities. Maybe next slide, we'll move into Zambia. So in the picture, you can see in Eastern Zambia particularly, there is a huge tribal community called the Ngoni people under a paramount chief. So what Amref has done with Ministry of Health, again, is to do an analysis of some of the areas within the country, even within a province or within a district which are not doing well. So we look at the performance in terms of vaccine uptake, vaccination rates, and then we are able to tell where the areas where they're not doing well. So this is one of the areas where we found that it was operating way below the national rate, which is 21% as we speak. But this area of the eastern region of Zambia was around 12% at the time we rolled this initiative. So we then analyzed the community dynamics, and we realized that at times the traditional leaders are quite powerful and influential. So we then use them and we call them the vaccine champions. So we educate them, we get them on our side, they become the advocates for the program, and they are able to mobilize people. As I speak now, from last week, our teams are deployed there. I'm told that last week alone, they were able to administer about 750 doses in one of these sub-chief areas, which again is an issue of taking vaccines to the people. So it means supporting our mobile teams to get out there, but of course, working closely with the Ministry of Health. One area in Zambia, again, which we have realized is the leaving behind of people with special needs. The people with the hard of hearing, the people blind, because most of the IC material, some of the awareness messages, they don't easily get them. So what we have done, other than training the 6,000 volunteers that have been deployed, is to work with ministry and the associations of people with disabilities to develop materials which can be used to raise awareness among these communities. And so far, in the last 2 weeks, we have been able to capture about 300,000 people reached with living with either with blindness or with hard of hearing. So some of the initiatives also we are doing in Zambia, but in general, maybe cutting across all the other regions, as my colleague said, one of the issues, in as much as we are really still behind in terms of availability and even the issue of choice of vaccines, as I speak now, I'm in Lesotho. Maybe you can show the next slide, the next photo. I'm calling from Lesotho, where we are also working with the ministry. So one of the issues we have seen, as much as we are trying to take the vaccines to the people through outreach sessions. This is a picture shows you a site in Maseru, behind one of the mountains here, where it's quite difficult to get there. But what I realized there today is that people come to this site expecting to get maybe the second dose of Pfizer vaccine. And actually, when we got to a site today, we found that they only have Johnson & Johnson, and they also have first dose. So that again complicates issues, and these are some of the things that we try to work around. So in other words, I'm trying to say one of the areas where Amref is trying to assist is the issue of data management. So that there should be quality, timely data, which all decision makers, planners are able to have access to, in order to make informed decisions about distribution, even about just telling the story about the reach. Because as we speak in Zambia, in Namibia, in Lesotho, we have quite a number of people who have been vaccinated, but for the data to move from the paper forms into the electronic system so that it's captured and reported, it takes time. So we have huge piles of data, and this way, again, Amref has come in to support ministries with training of data clerks, deploying them, ensuring that we, as much as people are vaccinated, where we are not able to do real-time uploading of the data, we are able to capture it so that it can go into the system and be used for decision-making. And then finally, in Namibia, again, where we are assisting the ministry to reach out, especially to the hard-of-reach areas. Again, in Namibia, one of the interesting regions, there's a region called Karongo, and one called Zambezi region, and the other one called Kunene. Sort of in the northwestern part of the country, which is just beyond the Namib Desert. The communities there are quite traditional, very low levels of literacy, such that it has become like there's a lot of stigmatization of people who get vaccinated, if I can put it that way. So we realize that those people who do go for vaccination, the community tends to stigmatize them because there is this whole belief of that maybe the vaccines are coming with all sorts of side effects. And therefore, what we have done after doing a gain analysis is to try and break that those myths and misconceptions and all that stigma. And one of the initiatives that we have done is to do evening vaccination drives. So the vaccination teams start going out into strategic areas and even into homes around 6 in the evening, all the way until 8, 9, depending on security and safety of the vaccinators. So in that way, we have seen that we are able to break some people really want to get vaccinated, but because of the fear of being seen to be vaccinated, then they tend to shy away. And then finally, across almost all the countries, including South Africa, you would have seen in the map that my colleague Jackie shared, South Africa is one of the 4 or 5 countries which has really done well. Last time I checked, I think they were almost close to 50% of their target of 70%. But across the countries, the biggest challenge still remains between the 12 to 17-year age group. And these are school-going kids, which our government started late to do. In that area, almost every country most of the countries are well below 10% in terms of uptake. So what we are doing, particularly in South Africa now and even Namibia, is to try and find models of integrating vaccination drive into the regular school health programs so that we are able to integrate vaccination into schools. But of course, this comes with community health workers talking to parents about issues of consent, ensuring that when the kids are in school, they bring the consent form signed and they're able to be vaccinated. So finally, in summary, my colleague said, one of the issues when you talk about wastage, I'm trying to avoid wastage, is the use of distances. So in the process of transporting vaccines to long distances, they are subjected to issues of breakages, but also issues of expiry. Just in Zambia 2 weeks ago, we got an SOS call from the ministry that they were in danger of, there was a danger of about 106,000 doses of Pfizer vaccine that were about to expire. So as Amref, what we did, we had to react quickly. Fortunately, Africa CDC agreed to our request and we were able to quickly mobilize mobile teams, go into all those areas where the vaccines were so that we save those vaccines from expiry. And again, thank God, all the other partners came on board, others, and within 4 or 5 days, all the 106,000 vaccines which were in danger of expiry were finally administered. So this is one of the things that we look forward to do to scale up the readiness to, when there is a call that in such and such an area, there are vaccines which are about to expire, we really need to be able to capacity and the readiness, agility to get in there and save that situation. I will pause here for now. Thank you.
Thanks, Boniface. Really, those stories were really helpful to just see what's going on in each country, especially the Zambia one, and how quickly we were able to react as an not only as an organization. And one of the things too is this isn't just Amref. We have partners in all these countries because so this is a major team effort. I think we have 11 major partners. And one of the things about this consortium, it's all African organizations that are running. And so really the integration with the ministries of health, the communities is so strong. And Jackie, do you have any kind of similar stories? Because we always end up talking a lot about Tanzania and Eastern Africa, but any other countries that you're working in that there's, on supply chain, because I know we're doing a lot of work on supply chain, the mobile units, school, any kind of specific, stories that you could talk about?
Yeah, yes, because we are in quite a number of countries. So for example, when you think about Djibouti, I remember as we microplanned with the Africa CDC, as we went into the country to try and identify what the gaps are and how we can assist, it was very shocking to realize that they do not even have their own sort of central storage facility. They've been renting this facility even for their childhood immunizations. So you can imagine the situation as you go lower into the districts, what kind of cold chain facilities do they have? Do they even have enough cool boxes? And we're talking of a population of only 1 billion people. So I think, like Boniface has said, we are at different stages. Some countries are doing fairly well, such as South Africa, but we still have some that are struggling quite a bit. And therefore, when you think about the asks in Djibouti, for example, it's for simple things like cool boxes, simple things like getting them a WHO-approved fridge, for example, to just ensure that they can be able to support the few vaccination centers that they have right now. I think as at last month, they only had 4 vaccination centers and 6 sort of mobile buses that were moving around the city, which is Djibouti, to just try and get people to get vaccinated. And I think that's part of the problem why the coverage is still so low in a country like Djibouti. And I think that situation is replicated in other countries like Eritrea, in Sudan, in Somalia, for example, the countries that we have in the Horn of Africa, as well as Ethiopia, where the population is very huge, a lot of need to support the mass vaccination programs, but not enough resources being dedicated to this. So yeah, the challenges are there. Yeah. Sorry?
No, you mentioned there was only 4 vaccine centers in Djibouti. What's stopping for more vaccine centers being set up? What is kind of the barrier?
Because setting up a vaccination center requires investment in resources, which is not a luxury in most of the countries that we have in Africa. Setting up a vaccination center, for example, requires that you put the right IPC, infection prevention control measures in that facility. You have to make consideration of the distance of that facility from the nearest regional store, for example, the kind of cold chain infrastructure they have in that facility, how many healthcare workers they have that can be dedicated to this. I know most of the low-level health facilities, for example, have 1 vaccinating nurse, and that's the same nurse who's going to be supporting the routine immunization for the children. So if we take this nurse and dedicate them to the COVID-19 vaccination program, then it means that no one is left to take care of the children who still need their vaccination. So quite a number of considerations. Sometimes it's tough because we are coming from a broken health system and trying to add on yet another problem on that, which means we have to act as we improve our health system overall. So quite a number of challenges to address, many considerations to make, but at the end of the day, I think we all remain committed to ensuring that as many people get vaccinated as possible.
Thank you. Boniface, do you have any comments you want to add to that? And also just, because we have a group of folks here who are already Amref supporters, and just always, what can they do to help do the work you're doing? We know the resources are limited, but I think a lot of times when we're talking about these big issues that we need millions of vaccines or billions of vaccines, it's hard to do. But, I know talking to you, like there's little things that we could do as donors that could make a real difference in the work you could do and the needs of the government. I think you're really tapped in these countries to know exactly what those needs are. So if you could share some of those needs, that'd be great.
Yes. Quickly out of head, Bob, as I said, because we have seen really that the issue of mobile getting out to where people are is quite pivotal, and it's non-negotiable in because of the terrain, because of the access to the formal health systems. So you talk about maybe sophisticated issues like vehicles, just the right kind of vehicles for teams to get out there, but also we think about simple things, because we spoke about the issue of community health workers. The amount of work they do in terms of volunteers, in terms of mobilizing, educating, following up, making referrals, it's massive. So a simple kit for the community health workers, which is just a simple phone, a bit of airtime, even just a $5 allowance for them to jump onto the next public taxi and people buy water. Those simple things make a huge difference in our programs. But again, tapping from what I saw even here in Lesotho and Namibia, people, communication and information is quite vital in this whole program. So you'll find that for not even a mobile facility, but even some of the the usual facilities, they are just disconnected from anything you can think of in terms of internet. So it means these health workers, they have to work the whole week, Monday to Friday, capturing data on paper. And then it means over a weekend, somebody comes and collects all these huge piles of forms, take them somewhere where there is access to internet and start entering this data. And it's so massive. So issues like just access to airtime, data, simple gadgets, but also if we go further, Jackie already, I think, spoke well about the use of the cold chain infrastructure and all the like. So these are some of the things. For example, in Namibia, one program provided these data clerks with simple basic phones. But then once the phone runs out of battery, for you to charge, it will take you another day or two to get to a point where you can charge the phone. So you'll find that simple things like solar chargers, where there could be a panel where a phone can be charged to keep these people connected, will go a long way to motivate these people, but also enable them to deliver. Thank you.
Thank you. You mentioned the school program, because I know we've been talking about in Kenya a little bit about doing it. And one of the challenges that we were facing in Kenya was we have the nurses, we have the vaccines, but there was like transportation issues to get them there, and that we weren't leveraging all our resources. And I know, Jackie, you were working on that too. Is like we have all these resources, but sometimes we're just having, as you said, the ability to get them there to leverage those resources. And I think literally we were able to do, just because of transportation costs, some really simple things. We're now able to vaccinate full schools, and we've started doing that work.
Yeah, which is quite unfortunate, because right now in most countries in Africa, the vaccination program is open for anyone above 15. And when you look at that population between 15 and 18 years old, that's the secondary school population in most of the countries. And it's really unfortunate because, for one, the nurses are there. We already have more vaccines that we need in the short term, just like I mentioned at the start of this. So our problem is no longer access, at least right now. It's about making sure that the vaccines that we have in our custody can get to the people who need them. Unfortunately, like Bob has mentioned, that's not always easy. And sometimes you have the vaccines in the health facility, but taking them to the university, taking them to our prisons becomes a challenge, because sometimes you don't have the vehicle. Sometimes you don't have the cool box for that. Sometimes the nurse is not able to split themselves. So yeah, the challenge is still what kind of vaccination programs we need to have to really make sure that we can take the vaccines closer to the people as much as possible.
Thank you. And I know Jenny's looking at me that we need to open it up to questions. So I will do that, Jenny, and I'll let you take over moderating that.
All right. So at this point, if anyone has a direct question, you're welcome and have the permission to unmute and ask Boniface or Jackie directly, or you can pop some questions in the chat and I can ask, or Bob can ask on your behalf.
Joe Piguet.
Yeah, welcome, Joe.
Thank you, Jenny. Jackie and Boniface, this is a very interesting challenge you have in front of you. And I can't imagine if you even have time to sleep at night thinking about all of these various pieces and how they have to be brought together and working with these different ministries of health and so forth. And I guess the question I have, a couple of questions. One, are you doing anything in West Africa, working with any ministries of health in West Africa? Two, to what extent do the ministries of health provide financing to cover your cost? Amref, or your role is more, I see it as a wholesale, if you're looking at this like a business, and you have to deal with the retailers, the distributors. How can you leverage your capacity as a wholesaler to reach more people by reinforcing the capacity of retailers, potential retailers? This could mean local health centers. This could mean community health workers, more broadly speaking, and also using your technology capacity to help generate the systems that the ministries of health and the retailers can use to provide you more information so it allows you to accomplish more.
Yeah, just a quick answer to one of your questions. Jackie and Boniface are focused on East and Southern Africa, but Amref is doing some work with other partners in Guinea and Senegal, but most of their focus is there, and I'll let them answer the other questions.
Yeah, correct, Robert. We do have just a little bit. So for example, in Guinea, one of the things that we're supposed to support them with is the demand creation. We are also supporting them in the COVID vaccination centers. And then, of course, we're also looking at how we can support them, develop their policies, update them. Because, of course, a lot has changed. When you look at some of the policies we had at the onset, we're talking about one vaccine candidate. But right now, most countries in Africa have close to 5 candidates of vaccine types in each of one of these countries, which means we need to update to ensure that our health workers have something to guide them as they roll out the vaccination program. So a bit of work in West Africa, a bit of it is around procurement. So one of the grants that has been funded by Africa CDC is around procurement of the IPC, the case management, equipping these hospitals, buying the rapid test to ensure that we can continue testing to just try and observe and track the trends in as far as infections is concerned. So yes, a bit of procurement, supporting the policy development, as well as the RCCE, the demand creation rather, and supporting the COVID vaccination centers. MOH financing, yes, we do have quite a bit of MOH financing, although there's a lot of expectation from the development partners. And I think this is part of the challenge that we have, because sometimes we plan and decide that we want to conduct the mass vaccinations, we come up with a budget, the MOH is only able to take care of a very small component of that, which means we have to rely on the development partners for this. Sometimes the funds delay, in which case we delay everything and the vaccination campaign becomes a little messy. So yes, the Ministry of Health is supporting, albeit in a small way. Most of the ministries of health are also supporting the procurement of the vaccines through the vaccine acquisition task force that is coordinated by the Africa CDC. So most ministries of health have committed money to directly purchase vaccines for their populations. And they're also supporting some of the vaccination programs that are happening in these countries. It's not enough, and that's why we need all hands on deck, all hands to support in whatever small way that we can. And I think, like my colleague has said, sometimes the help that is required is quite small, and yet that has such a huge impact in as far as making sure that the vaccination can get to the people that it needs to reach. As far as retailers, how do we ensure that we can use the resources that we have, the health facilities that we have? Most of it is around capacity building, because I think that is something that Amref does well. So direct training of the healthcare workers, developing of these curriculums, putting them into e-learning and mobile learning, because once you convert that content, have it on the mobile phones or have it on e-learning platforms, then many healthcare workers can be able to access this at the same time, in which case, anytime you have a new vaccine candidate, all you have to do is alert them on the mobile phone that we have new courses for them to go through, and we can see quite a number of healthcare workers logging into that, not just in one particular country, but this training is available across different countries in the region, which means we can be able to we can be able to kill several birds with one stone. Yeah, so that's one of the technologies that we are using, especially our E and M training platforms. The others are really, most of the governments have already developed their technology for the data management. Some of them have adapted the usual district health information system. It's called the DHIS, and that's what they've adapted to meet the needs in the vaccination program. And therefore, what Amref is doing is coming in and working with them to really evaluate the functionalities of these systems. What do we need the systems to do, and how can we support them to be able to do that? Like I mentioned, in Djibouti, for example, their system was not able to provide the vaccination certificates once you're fully vaccinated, and therefore working with them to develop that functionality. In Kenya, they did, we now have the booster doses in Kenya, and therefore we needed to change our system to ensure that it captures that kind of data. Once you're fully vaccinated, then you take your booster dose, the system needs to show that. So it's continuous development. It's checking where they are with their electronic system, looking at what kind of functionalities they need, and working with them, identifying the right vendors to ensure that these developments are done in good time. I hope that clarifies. I don't know if Boniface, you have something to add.
Thanks, Jackie. That was great. Does anyone else have any questions?
Yeah, we have a hand raised by Kathy. Feel free to unmute.
Yeah, thank you. Thanks. And afterwards, I'll lower my hand. But if I try to do that now, I'll disconnect myself or something. Kathy Toner here from the Packard Foundation. Many congratulations to the presenters. They were terrific presentations. I learned a lot. Thank you. Thanks for the work you're doing. Like Joseph, I can't imagine what it's like for you day to day. I guess I just have one question, and if there's time later, I'll pop a second one in. But I really liked the way you talked about what you're needing to overcome to actually get vaccines into people's arms. And I heard three things. That I heard hesitancy, that's distrust, stigma. I heard the barriers to access, that you've talked a lot about how you need to overcome barriers to access, people that want the vaccine, and then the third one was, if I understood, this is the way I'm thinking about it in my head, is sort of apathy, just like, I don't really need this. So I'm wondering if that makes sense to you, like there's outright kind of, I don't want this, I distrust it, I think it's going to hurt me, or I don't think I need it, because how would you break down overall, which is right now getting in the way the most? Is it just that it's the access issue? Is it that hesitancy and apathy, or is it outright distrust, stigma? And then just quickly, what's really working against those last two, hesitancy, distrust, and then separately, the way I would think about it, apathy, I just don't really need it. Hope that's clear, and thank you in advance.
Yes, and really good question. And I'll call in my colleague to also explain a little bit about what's happening in the South. So in as far as access is concerned, like I mentioned, we sort of have enough vaccine for the near future, but not enough to reach what we need to reach our 70% target. But that said, even when you look at the in-country coverage, there is inequity in the way the vaccine is being accessed. The closer you are to the capital city, the higher the coverage. The further you go, the harder it is. And therefore, sometimes even with the Ministry of Health, they call on us to help them deliver some of these vaccines using the flying doctors, because there's no vehicle that's going to get there. Pfizer, for example, requires that it cannot be on the road for more than 7 hours. And what that means is that we have to look for ways and means of getting that vaccine to where it's needed in the shortest time possible. So there is inequity within each of the countries, where the closer you are to the city center, the better it is, the easier it is for you to access, because of course you can access that from a static COVID vaccination site. If you're in the vast areas, access becomes a problem, because most of the people don't live more than 5 kilometers away from the health facility, which means we have to look for ways of getting that vaccine closer to them. So access is a problem, especially for people who live away from the city, but in the city, the vaccine is there and people can easily access that. I think the other thing that is affecting us and most of the African region is the low risk perception. And this has been the condition from the onset. Most of us have felt that we are not particularly at risk, especially for the young folks, anyone below 35 years. Because even when you look at the numbers that are getting to hospital, most of them are people above 50 years of age. And therefore, most of the people fail to understand what their role is in breaking transmission. That part of the reason why you're taking the vaccine is to protect others, even if it's not just to protect yourself. So one of the things that's affecting us, it's the low risk perception. And most of what we are trying to do right now is trying to explain to them that sometimes it's not always about you. Sometimes you do it for others. So there's the low risk perception. There's apathy, because that's the kind of discourse that we are hearing from the rest of the world. We have countries that are dropping the mask mandates. And therefore, there's a feeling that COVID is gone, not forgetting that our coverage is still very low. And therefore, the populations that are at risk are still at risk, whether the masks have dropped or not. And therefore, it's a rush against time for most of us, because we want to try and have as many people, high-risk people, covered as soon as possible before everybody thinks that COVID is not here anymore. So it's a rush against time. It's a rush we are trying to be as targeted as possible to ensure that anyone who needs to be covered is covered. So how can we ensure that we reach our older persons? How can we ensure that we go to schools and cover the teachers who are working there? How can we go to our healthcare workers and ensure that they are covered, including our military? So it's about getting strategic. It's about reminding people that it's not over yet. So it's a combination of many things, and it's different based on where you are. Boniface, I don't know if you'd have something to add.
Yes, quickly to that question from Kathy, but I wanted to acknowledge Joe's thinking around the issues of leveraging retailers. I think that's a great idea, which I wanted just to echo. I've seen that work in South Africa, where these giant retailers are actually within their cold room facilities are providing access to storage for vaccines, and it's working because fortunately for South Africa, maybe because of development, you find these giant retailers even in rural areas, and they've negotiated with Ministry of Health to be able to store those things. We have tried to borrow that idea to a less developed country like Malawi, for example, where they rely on what we call communal pharmacies. These are like medicine stores which are run by an individual in a community, somebody who just set up a tuck shop to sell the routine self-prescription drugs. So we have been thinking in Malawi to say, how can we leverage these people because they live within communities? Could we put them in some training program, resource them, get Ministry of Health to accredit them so that they're able to also participate in those? So I wanted to acknowledge that and say, I think that's a terrific idea. It's great, we can look into that. But back to Kathy on that question, Jackie, you are right. The issue of demographics and what I will call demographics and geography comes in very strongly in terms of you cannot really point and say it's about hesitancy, it's about complacency. It really differs from one place to the other. I will certainly point out, and I will continue using South Africa because there is so much data in South Africa and because of the magnitude of the coverage, which is quite high. So you are able to tell in South Africa that there are two currently really lagging groups. One is the 12 to 17 age group. These are children in high school. So the question is, because one of it is about the issue of parental control. If parents are not for vaccines, definitely these kids will not get vaccinated. So it's about how do you break that cycle of getting parents to consent and allow their kids to be vaccinated. 2 weeks ago, there was a story on TV where a child came back to school because they're able to consent at 16, said, I'm vaccinated, and the parents said, you are not going to stay in my house as long as you're vaccinated. So they called the minister and said, can you take this child and keep them in their own house? So that on its own, again, is an issue of, it's a barrier on its own. Then we saw in South Africa, interestingly, the age group from 18 to 24, when it was open for them, they vaccinated in big numbers within a short space of time. These are student-going universities, university-going students, college students. So again, we looked at it and said, what pushes these kids at this age to take up so much? Then if we look at the current data in South Africa, the most complacent group, the people who believe they have the strongest immune system, are the 24 to 39. There's a huge gap there. For one reason or the other, I think maybe they believe that they can easily, they have the right immune system. But again, you will go into communities, especially those traditionally and predominantly rural areas where access to information is very difficult, where there are huge issues of misinformation. In Malawi, that's why we have 9.7%. The most populous region, it's very traditional. It's a closed communities. It's very, very difficult to get them to vaccinate unless that's where you need to do massive awareness, massive education, massive advocacy. So what in short, this issue of what is really the issue, it varies from one place to the other, from one age group to the other. Thank you.
Thank you, Boniface. I think we are at our time, but I do want to acknowledge, since it's the Packard Foundation support for providing technical capacity building for the Africa CDC. They're a major supporter. So Kathy, thanks for joining our call and the incredible work that the Packard Foundation is doing to support the work of the Africa CDC is much appreciated. And Boniface and Jackie, thank you so much for your time. We're going to probably drag you back in maybe 6 months so you can kind of update us where we are. But thanks everyone for their time. I'm sorry we didn't get asked a few more questions, but there will be a next time.
And if you're all interested, at the bottom, there are links on how you can help more, and some answers to the questions will come on the follow-up email. Thanks, everybody.
Thanks, everyone.
Thank you for organizing this. Very interesting.
Joe, it's great to see you.
Thank you, everyone.
Hi, Liz.
Thank you.
Trying to unmute.
Thanks, Dr. Parson. Yes, we can send answers to anyone and connect. We will have the chat transcript.
Yeah. Jackie and Boniface, thank you guys so much. That was such a dynamic conversation. It's just, I feel very informed as well. You're doing a great job.
Yeah, I see Crowley. Marie Crowley is asking she's in Kenya, Nakuru.
Yeah.
And she's asking how she can get the school vaccinated. So if you can get her contact for me, I can try and link them up because we have an active project in Nakuru.
I love that, Jackie. Okay.
Yeah.
Boniface, thanks for moving.
Very much. Thank you.
Beautiful light shining on your face.
Okay, thank you. I just came from the field and I was rushing. I had gone up the mountains and it was good.
You're busy guy. Amazing. And Joe, thank you so much for your great question.
Yeah.
Thank you. Bye.
Okay,
yeah,
bye.
We'll let you guys go. We'll let you guys
Joe,
go.
you're on mute. If you're saying something, Joe, you're on mute. And Jackie and Bonnie, we'll see you guys.
One last question, Jackie, before you sign off. How are you guys fitting into Amref organizationally? Are you part of the program department or are you part of the economic development group? Amref Enterprises Limited.
So we are in programs and we are both working for the Global Health Security Unit. And this unit was recently established because we realized that we've been doing quite a bit of health security work, lab system strengthening. We are part of the Ebola response. We are supporting quite a number of countries to come up with guidelines for addressing health emergencies. And so we felt that it would be good that we consolidate all this experience and consolidate the coordination of this work under the Global Health Security Unit. And this is coordinated from HQ, but every country has the teams that are working in the health security programs. So Boniface and I are both under the Global Health Security Unit under HQ.
Okay.
Yeah.
Thank you very much. We can talk some more about your approach. Thank you.
Yes, thank you so much. Thank you.
All right, guys, we're going to sign off here. Thank you again for everybody's time.
Thanks so much.
Goodbye.
Great job.
Bye, everyone. Bye.